been talking this morning about the anatomy, and the first thing is just have a really good look round and make sure you're comfortable with the anatomy. And you can see here, the first thing I do the same, in real life, is I've got stay sutures on the right appendage and also on the left appendage. And I find them very helpful just to really clear things away from around the great artery. So you see the left appendage here, and you can actually take the stay suture behind the heart, and it tucks the left appendage out of the way. It gives you nice access to the left pulmonary artery and a clear view of the left coronary. So you can see, usually in transposition, the position of the coronaries very clearly on the surface of the heart, and they're nicely demonstrated in the model here. And you can see, remember, here's the non-coronary sinus. So here you are, the surgeon, standing in the non-coronary sinus. And here's sinus 1 to your right hand, and that's the left coronary system. And to your left hand is sinus 2, which is the right coronary system. And I say the first thing we would normally do is to actually look after the duct and make sure it's secured and divided, so you haven't got to worry about it for the rest of the case. But we can ignore that now. But I would normally, ligate the duct, free up the whole length of it, ligate it at both ends, divide it, and oversew both ends, so that you're not in any risk of it bleeding. So, your first thing with your models is we're going to transect the aorta. So you've given your cardioplegia, cross-clamp the aorta, and you just have to get your bearings and make sure you've worked out where you're going to cross-clamp, where you're going to give your cardioplegia, and where you're going to transect the aorta. You can see here roughly where the sinotubular junction is, and you certainly want to be well above the sinotubular junction. So you usually end up giving your cardioplegia slightly higher than you might do in a normal case, but then coming usually around 5 or 6 millimeters above the sinotubular junction is your first maneuver. But once you've opened up, I usually stop, look inside, make sure there's no surprises at the back of the aorta, and then try and transect it absolutely perpendicular to the plane of the aorta, and then straight away it should get a nice view inside. And you're seeing that on the camera there, Brandon. We okay? Yeah. So the first thing I do is get some stay sutures in to make sure we have the anatomy clearly demonstrated. I hope you've all managed to get hold of some sutures wherever you are. But looking inside, as I say, you're looking in this. There you go, Zane. Have a few over there. Your landmarks of the top of the commissures of the valve. And there's one there. Sorry, this thing. And they're quite soft, these models, so you don't want to put too much traction on your stay sutures. So
you want to
a little bit. We'll try that. Yeah. It's nice material to work with, but they're quite flimsy, so you can't put too much traction on your stay sutures. I don't think so. I think they're a pretty good approximation to the real thing, actually.
Well, you tell me that if you find that there's something you think you should modify, and feel free to make any modifications.
So your 3 stay sutures go in, and I say you're kind of often itching to get on with the surgery at this point, but it's really important to get yourself nicely set up. Moving it around, you see, so you can't really stick it down. Okay.
Okay.
So as I say, one at the sort of top of each commissure. There's the sort of posterior commissure there. There you go. So if you hold that for me, Zainab. So you kind of look inside, make sure you're comfortable where the coronaries are. And I usually find it easier to take out the right coronary first. So you can just hold this one for me, Zainab, as well. You really try and take out the whole sinus, really. So you start right down, heading for the commissure itself. If you use curved scissors, I tend to keep the curve facing outwards towards the commissure. But you want to keep your button as big as possible because it makes your life easier for the whole procedure. So really going down into the base of the sinus, and the same coming down from the other side. But you really try and maximize the size of your button because it gives you much more leeway with the reimplantation. Okay, there you are. And this kind of soft silicone on the model is a nice sort of approximation of the reality of what you see with the kind of connective tissue around. So I think we were saying today you can probe the coronary if you need to be sure you understand where its course is on the surface of the heart. And usually there's a little bit of mobilization. I know that some surgeons like to really skeletonize the coronary, but usually just enough to free it up so it's nice and free like this. And you can see how it's going to move across to come to the aorta, but not so loose that it's kind of flapping around in the wind. But there you are. And then I go to the left. And again, I think by taking the right out, it's giving you a better view of the left. And again, we head straight for the commissure. I just relax a little bit on there. That's it. Both sides. You take on a nice big button. That's it. So same again. You can probe the coronary if you need to be confident you understand the pathway of the coronary. But you have to really free it up from the floor of the heart so it lifts out. That's it.
By doing that, do you have any risk of cutting the septal forward?
No, they don't start till you're further along. So I think if you just limit yourself to this immediate origin, then you're safe. There's usually nothing from the left main here. That's great. So you now have a choice. I say my preference is that I actually now put my patch in at this stage to repair the defects in the aorta at this point. But we'll move on to keep moving. And we'll just get on and do the coronary reimplantation. So we'll use our stay sutures to hold things out of the way. Okay, so I say my preference would be to actually put my pericardial patch in now to repair the defects, but we can do that later if you want to today. And then, so our next movement is, so we're going to transect the main pulmonary artery. You haven't usually got much choice because you don't want to go right onto the branch pulmonary arteries or you'll end up with problems with the pulmonary arteries in the long term. But obviously you've got to be above the sinotubular junction. So usually just coming in just sort of halfway between the sinotubular junction and the point of bifurcation. But again, trying to get a nice straight perpendicular division of the pulmonary artery. And then same again, the first thing I do is put my stay sutures in. So I say, please shout out if you want to ask a question or make a comment. I'm sure everyone does it slightly differently. So again, marking the commissures, this is nicely aligned. They say we'll use the sort of medially hinged trapdoor technique for these first ones. You know, the switch is a typical kind of neonatal procedure where you really have to display everything carefully and just take your time, and you end up with a lot of little stay sutures and cannulation sutures everywhere, but you just have to find a system to keep things as tidy as you can. So here we are with the pulmonary route now displayed. Again, get your stay sutures as you want them. And as we look inside, is that coming up on the camera? Yeah. So you're looking inside, you can see where the valve commissures are and the leaflets are. So I start with the left. And again, you want the left to tell you where it wants to go. So you try to have everything without tension on it. But let the left coronary button tell you where it wants to be. And it's pretty well always right in the middle of the sinus. You want it to have to move its minimal amount. And that to me looks like about right. And it's about bang in the middle of the commissure. So we're going to cut our little medially hinged trapdoor. You can just hold the button for me, Zainab. So first of all, we come down almost vertical. And I say often not too far, because you want the coronary to sort of sit up and beg a little bit to come up. It's not quite deep enough there. But I think you do often find the coronaries are higher up than in a normal aorta. And then you make the little medially hinged flap. Okay. So there's our flap. And the coronary is going to go in here. And I think you can choose how you like to do it. Some people like to attach the midpoint or the nadir of the button to the nadir of the trapdoor. I find it easier to start at the top and work my way down. But you have to be comfortable that you think you've judged things about right at the beginning. Where am I? So here's my left coronary, and I would estimate I need to start about here because my coronary button's nice and tall. I'm not going to need it all. That's it. Yeah, that's it. Pop that out over on that side. Yeah. Yeah. So let the button come towards me, Zainab. That's it. That's it. Yep, let them come together. Yep, so this is where you're grateful for taking a nice big button with plenty of tissue so you don't get too close to the coronary ostium itself when you're putting the button in. And all the time you're just trying to watch your distances. Stay sutures are really important to help you. So here we are now at the sort of lowest point. So here I come through the button. And then just reposition my body. So just stop a second. At the other end of the stitch. So I take this feeder up, Zena. I take it over this way. And now you can sort of change direction. And let's run the, so again, just take the button for me. And then fold the button in like this. Oops. So this is the sort of trapdoor hinge, which I think just helps to minimize the rotation on the coronary. Allows the kind of neo-aortic wall to come out to meet the coronary. But it does, of course, increase the size of the neo-aorta and gives you that sort of bulbous aortic root that we all recognize in the post-arterial switch patient. So pretty well at the top now. I don't need to. That's it. So let me take that one back. Take that one back to your side. I hope that you can see that okay. So there's the sort of left.
At the same time, the same place.
Yeah, I think so. Just not too tight, so that we can let people see. So I'm not going to need the top of the button. And here, as I say, as you look inside, hopefully, or you really should be able to see the ostium. Hope you can see the red ostium right in the middle of your button. And so you know you've not impinged on it in any way. And on the outside of the heart, you can see the course of the coronary isn't being kinked or twisted. And there's your nicely sort of situated button. And the right is very similar. So I'm just trying to get out of our way. Take that on your side gently. Just not too much tension. But again, really, I want the right coronary. I say we need to make sure we've not got tension on anything. So if you can just hold that. Here's the right coronary, and again, you want it just to tell you where it wants to be, and usually that's in the middle of the facing sinus. So again, it's a little kind of medially hinged trapdoor. Zeno, do you mind just taking the right column? Yes, sorry. Our stay sutures are marking the coronaries for us. And again, so it's usually in the middle here. And again, we come down in the middle of the sinus. And then it's just medially hinged a little to make that little flap. That's probably all we need.
Hi guys.
Yeah.
Could you please clarify how deeply you have just cut into the sinus? I mean, to show how deeply you have cut.
Yeah. You mean in making the trapdoor?
Right. Right.
Well, you have to redecide. I think you often end up almost still above the sinotubular junction.
Okay.
So you're judging it really by where the coronary wants to be, and you want to keep it pulled up a little bit straight. So you don't want to go too deep into the sinus, or the coronary can sort of buckle up at the bottom. So you want to pull it up straight almost. So you tend to keep a little bit higher than you might imagine where the coronary would be in a normal, if you looked in the normal aorta. So it tends to sit a bit high, but you have to just judge it in every case and let the coronary button tell you where it wants to be.
Okay. Yeah. Thank you. Thank you.
So again, we start at the top I start at the top. You could start at the apex if you like. But again, my button's nice and tall. I'm not going to need it all. Well done. So then everything step after that one for me. You can click the word out somewhere. And again, it's the thing of having a nice big button of tissue to work with. And of course, you know, everyone's a little bit different, and sometimes you'll find that the ostium of the coronary is not right in the middle of the sinus where you want it to be. So you have to be careful. You don't want to end up with the ostium so close to the edge of the button that you're risking it with your suture line. So if you see that, sometimes it's better to take down the commissure of the valve, of the patient's aortic valve, before you take the button out. And that allows you to take a bigger button that includes, that allows the ostium still to be more in the middle of the button. And you can always just resuspend the commissure, because that's going to be the pulmonary valve, and it's usually pretty forgiving. That's it, thank you. This is always a bit awkward, I think, surgically, I find, because you're kind of working slightly underneath yourself. But as soon as you finish this first run, and you can turn the coronary round, it gets easier.
Assistance is important.
Yes, you've got to have a good assistant. So I apologise for Zainab. She's doing great. Hope her nail varnish isn't too fluorescent.
Yeah. It's my signature.
So again, just like we did with the left coronary, once I get to the very kind of apex here. Oops, where are we? That's it. Needle comes out. That's it. I just need to move my stay suture slightly. Have I picked up the right one? Yeah, there we are. That's fine. Yeah. And then you can change your body position. and coming up the other side's a bit easier.
Change my hands.
No, you're fine.
Yeah,
I think we're okay. So you can just. Sorry, this lead might be. That's it. There we are. Oh, sorry. But, you know, keeping your spacing right and nice, strong bites of tissue here saves a lot of pain later on in the surgery. So you don't hopefully get too much bleeding. But I think again, it's so important just to have a big button, because even if you, for some reason, get it wrong or don't judge it right and you have to redo it, the fact you've got a nice big button of tissue again is much more tolerant. It'll tolerate being sort of undoing the suture line and redoing it again without damaging the coronary and so forth. So a big button is the key. You know, and taking your time, because you're always tempted to try and rush, but it's as long as you've got the coronary right, everything else will be okay. And again, sort of have a sort of a discipline, a kind of routine in the back of your head, so that once you've done the coronary button, you stop. I usually probe it with a tiny coronary probe and make sure I'm happy with it before you go on to the next step. Okay, I'll stop there. Okay, so there's the right coronary, and again, so you have a look inside. So that stays in the way a little bit. Make sure you can see your ostium. There's the red ostium looking at us. I probe it. You can look on the surface of the heart. You can see the right coronary looks nice and straight. As you say, it's pulled up a little bit straight, which is exactly how you want it to be. And then you look at the, looking out the front of the aorta, you can see those coronaries look as you'd want them to. Nicely pulled up straight, not kinked, and right in the middle of the sinuses. So there you are. That's the medial hinge trapdoor. So then obviously you do your Lecomte, and your new aorta has to come to here. But of course, because of that coronary button that's now in the pulmonary root, you've got a much longer circumference to the new aortic root than you have to the aorta when you put them together. So you have to make up that difference when you do that anastomosis. That's very important. Okay, let's stop, and then Asami can show you the closed technique.